My name's Dr. Joe Mills. I'm a consultant cardiologist in Liverpool. I'd like to talk to you today about the primary care atrial fibrillation or PCAF service that is delivered by Inspira Health. I've been involved with the PCAF service now for a number of years and have been impressed with the success and the outcomes that have been achieved by the PCAF service. Going back a few years before the start of this service, there was clearly a big problem in the UK with both the prevalence of stroke that could be avoided and the number of avoidable deaths due to this thromboembolic stroke in the setting of atrial fibrillation. We know that certain groups of patients, particularly those with the higher CHADS2 VAS scores, in fact any score above 0, are at significant risk of thromboembolic stroke, whether they have either persistent, chronic or paroxysmal atrial fibrillation or flutter. Unfortunately, a significant number of these patients were being denied the appropriate treatment or were felt unsuitable for anticoagulation therapies. The success of the PCAF service has been due to a couple of factors. The first is that there was a clear need for better patient management and improved understanding of the need for anticoagulation therapy for patients at risk of stroke who had underlying atrial fibrillation, and a clear directive at a national level that more than 15,000 strokes could be avoided if patients were adequately and appropriately anticoagulated, with the saving of perhaps 7,000 to 10,000 lives per year. In addition to this, a number of new so-called NOAC or novel oral anticoagulant drugs had come to market, and yet we had little experience in the UK of using these drugs, particularly in a primary care setting. The PCAF service was designed to allow appropriate patients to be identified, screened and then interviewed, ideally by a specialist, to discuss their anticoagulation needs and the options for them. It's for this reason and the systematic way in which this has been carried out within the primary care setting that the PCAF service has produced such tremendously good results, both for the health economy as a whole, but most importantly for patients with atrial fibrillation. The actual service comprises a number of different phases. The first of these phases consists of improving the atrial fibrillation register by screening the data set for clues of patients with atrial fibrillation that have not yet been coded as such. This provides a more robust and certain measure for primary care physicians that their AF register is intact. The national prevalence of atrial fibrillation is somewhere between 1.4 and 2% of the adult population, depending upon the age demographic. We certainly have found through using the PCAF service that there's a huge variation in AF prevalence even within CCGs with a similar age demographic. The phases of the PCAF service that look into this help to reduce inequity amongst patients who then can be screened for the need for anticoagulants. Subsequent stages of the PCAF service involve running assessment tools to look for those patients who are not on anticoagulant therapy but would be deemed high risk for stroke because of their risk factor profile. This patient list can then be reviewed by Inspira Health staff who are well trained and appropriately qualified to review these patient details and assess whether or not such patients should be seen to discuss anticoagulation. The result of this over a number of years is that more than 65,000 patients have been identified as possible or potential patients that should be seen, and over 8,000 patients have been seen in a primary care setting, usually by a specialist cardiologist or stroke physician or perhaps haematologist, to discuss with them face to face about their atrial fibrillation and their anticoagulation requirements. The output of this has resulted in a huge saving to the health economy and to the patients. We would estimate that the annual saving to the NHS has been in the region of £4 million, that more than 350 strokes have been avoided, and that perhaps somewhere in the region of 200 lives have been saved during the relative short time of the PCAF's existence. On a personal note, I've been involved in the PCAF service delivering the consultant specialist review of patients in a number of different practices. We've provided educational time for general practitioners, nursing staff and anticoagulation specialists to sit in with these clinics to understand how we approach these discussions and talk to patients about all the different anticoagulation options, including the more novel anticoagulants. I'd like to describe one such patient to you. Gladys was 78 years old and she had atrial fibrillation for more than 15 years. She was taking low-dose aspirin as well as treatment for her hypertension, diabetes, and had mild left ventricular systolic dysfunction. Unfortunately, around 5 years ago, she'd suffered a severe fall. At that time, she'd been on warfarin therapy. She'd had significant bleeding at the time of her fall, during which she'd broken her hip. She had lost her confidence with warfarin therapy. It had complicated her fall, and the physicians at the time within the hospital setting felt it was reasonable to withdraw her warfarin and maintain her on aspirin therapy. Her general practitioner had quite rightly discussed reintroduction of warfarin on subsequent occasions, but unfortunately Gladys had understandably lost confidence with warfarin therapy. I was able to discuss with Gladys all the various options, including the new novel anticoagulant therapies, as well as giving her the option to reconsider warfarin therapy. Clearly the advantages of the new drugs, whilst perhaps not altering the bleed complications that might be associated with significant falls, are the ease of use and the very, very low rates of fatal and life-threatening bleeds associated with these new drugs. Gladys was very happy that she'd had an enormous amount of both written and face-to-face information about all her treatment options, and was happy to take one of the new oral anticoagulant therapies and to discontinue her aspirin. I think it was only through the PCAF service that this situation would have come about, and that Gladys would have had the confidence and the information to make this informed decision. I'm very proud to be part of this PCAF service. I would certainly recommend that it is used extensively within a primary care setting to particularly support those primary care clinicians who do not yet have the confidence to use these newer drugs, and to advise patients about anticoagulation in a more specific and specialist manner.